Hi, everybody. Gosh, what day is it? Is it Wednesday? Yeah, Wednesday to everyone. My name's Rebecca. I'm the CCRN instructor with Archer Review. Welcome to our next webinar. We've been doing these weekly for the last few months and mainly going through practice questions to help you study for your CCRN. So if you're joining here on Zoom, happy to have you here. I've got the chat open, so definitely feel free to use the chat to communicate with me and put your answers in when we go through these practice questions. And then we also are streaming on Facebook and YouTube. So I'll try to stay up with both of those chats going at once, which sometimes I'm not too great at. But we'll see how it goes. If it is your first time here, my name, like I said, is Rebecca. I've been an ICU nurse ever since I graduated nursing school. Love critical care. Love encouraging people to take the CCRN, which is the Critical Care Nurse Certification exam. I think there's so many benefits to being certified, and no matter what specialty you're in. Um, but definitely as an ICU nurse, I just think it's a really good idea. Hopefully, your hospital reimburses you for becoming CCRN certified, either by paying for your exam or by offering some sort of shift differential, yearly bonus, some sort of incentive for being certified. If you're interested in going back to school for nurse practitioner or CRNA, it's also a really good thing to have on your resume being certified in your specialty. So, yeah, like I said, we are going to just take a quick 30 minutes to go through practice questions. I already gave a pretty quick rundown of the CCRN. Like I said, it's the Critical Care Nurse Certification. You can take it after about a year of experience. I've definitely heard the advice out there to start studying for your CCRN, maybe as soon as you get that ICU nurse job, whether you're a new grad or you were just new to the ICU, you've been working somewhere else in some other unit. Not in the means that you're going to take the CCRN super quickly, but just the act of preparing for the CCRN will help close the loop on so many different concepts. That is the biggest feedback that I hear from nurses who are taking their CCRN. As they were preparing for the exam, there were so many things that came up for them that they just thought, I can't believe I didn't know this before now. And that was exactly my experience as well. I actually waited quite a bit of time to take the CCRN. I'd been an ICU nurse for, I want to say 4 years, which is a good amount of time. And I thought, oh my gosh, I've been an ICU nurse for 4 years. And there were certain things I learned through the preparation process that I just hated that I didn't know before then. So, would love for you to pass your CCRN, become certified, but just know that the process of preparing for it does a lot of good as well. Here at Archer Review, we do have a product out for CCRN preparation. So we've got a question bank with over 1,000 questions, practice questions. We have 13 plus hours of on-demand video lectures, and then we do these webinars weekly, typically. So you can use all of this to help you prepare. We've got a kind of a subscription service for it, or you just pay for a certain amount of time. So you can have a 3-month option or a year-long option, which might be appropriate again if you're just wanting to start preparing for the CCRN, but not necessarily test very soon, but just have access to those resources as you maybe are entering the ICU for the first time. So go ahead and tell me, especially if you're here on Zoom, tell me who's here, where you're from, if you've got your test scheduled for CCRN. Just give me a little insight on who's here. Think I think I see some names that I recognize for sure. So I think we've got some people back, which is awesome. From Miami. Oh, fun. I've only been there once, but I want to go back. Sienna, awesome. Okay, as y'all continue to chime in, I'm going to go ahead and we can get started with our first question here. Um, with these questions, I'd love for you to answer in the chat from Oregon. Awesome. I'd love for you to answer in the chat just so that I can see what are the common thoughts and answers as we go through these, and it'll help me know what to explain. Woohoo! Yay! Shakira passed her exam. Yay. Thanks for coming back on. That is so exciting. I'm so proud of you. I'll look for your email. I'll send you an email later and congratulate you. That's awesome. Thanks for popping in and letting us know that. Shakira has been coming to webinars for I don't know, maybe like the last 2, 3 months. So excited to hear that you passed. That is so exciting. Thanks for letting us know. So yeah, like I was saying, go ahead and give us, you're so welcome, Shakira. Thank you for all of your interaction on these webinars. It's been so fun to work with you in this way. So yeah, as we work through these questions, pop your answers in, and then I can know what I need to explain further. So let's break down this first question. Which electrolyte abnormality is most commonly associated with severe acute pancreatitis? This is a hallmark symptom. So this one is one of those ones that you'll definitely want to know for pancreatitis. Exam in August. Okay, lots of preparation. That's good. Oh, Shakira, I'm so excited. I had no doubt that you would pass that exam. So, love to hear it. Okay. Yeah, you know it. That's right. Yeah, so the answer for this is C, hypocalcemia. Again, cardinal symptom for pancreatitis. Can anyone give me, it's kind of wordy, but why do we see hypocalcemia with pancreatitis? And you can just give like keywords for that so that you're not typing a ton. But there's a few different reasons out there that we see this hypocalcemia. And for me, when it comes to remembering what electrolyte disturbances are common with what conditions, if I can wrap my head around why that electrolyte disturbance is happening, I can memorize it a lot easier, remember it a lot easier. So with calcium, the reason that we see this hypomagnesemia is mainly due to calcium um, there being free fatty lipase releases these free fatty acids into the pancreas when it's in pancreatitis, and it's going to bind calcium and allow it to turn into these calcium salts and soaps that are released into the abdomen. So if they're in the abdomen, in that abdominal cavity, they're not in the bloodstream, and that's what leads to that hypocalcemia. It also can affect things like our parathyroid hormone, which can affect our calcium concentrations. Lots of couple different reasons why we see that. Now, other electrolyte disturbances that we see, obviously not hypercalcemia because we're seeing hypocalcemia. We can see a little bit of hypokalemia depending on if the patient is having lots of vomiting or diarrhea. That can lead to hypokalemia. And then we typically are going to see hypomagnesemia alongside that hypocalcemia. Those usually work in the same direction. So whereas calcium and phosphorus have an inverse relationship, calcium and magnesium have a direct relationship. And here's just a little info on pancreatitis. And we can see that diagnostically, we see that hypocalcemia, and we're really concerned for acute pancreatitis. It is a hallmark symptom. Okay, let's move on to question 2. A patient with hepatic encephalopathy is confused and lethargic. Lactulose is ordered. Which finding indicates effectiveness? Nice. Yeah, a couple different answers. So that's good. I always love when I see different answers because it means that we have something to talk about. Good job. Yeah, so the answer for this one is going to be B, 3 soft bowel movements in 24 hours. Now, that kind of can sound a little interesting. We don't know what the effect of like what the symptoms look like, all of that to know its effectiveness. But lactulose should cause some soft bowel movements, usually 3 to 4 a day. So if it is working, we will see those increase in bowel movements. So 3 soft bowel movements in 24 hours is exactly what we're looking for. Serum ammonia, this serum ammonia is still a little bit high, quite a bit high. So this would not be indicating effectiveness just yet. We would not want to see increased confusion and asterixis. That's telling us that we still are pretty encephalopathic. And then our potassium, we should be monitoring our potassium as we know that diarrhea can cause hypokalemia, but it's not going to be telling us whether this is an effective medication or not. Okay, awesome. So yes, answer for that one is B. And there's some information on encephalopathy, particularly that hepatic encephalopathy, where we see that elevated ammonia level, and we will give lactulose for elevated ammonia. We want that ammonia below 50, so that ammonia in the 90s was still quite high. Okay, let's move on to this one. A patient is 24 hours post Whipple procedure and develops tachycardia, hypotension, and new abdominal distension. What is the priority nursing intervention? Not too many answers just yet. I can go ahead and talk about it. Seeing a couple different things. Okay, so we've got a Whipple procedure. What is this is obviously a abdominal procedure involving the pancreas, stomach, bile duct, duodenum. It can vary kind of in everything that's involved in it. But we have this person who's post-op abdominal procedure. When you think about abdominal surgeries, think about how vascular the abdominal cavity is. So we've got lots of blood flow going to these major organs. If this person is 24 hours post-op and they develop tachycardia, hypotension, and new abdominal distension, what are we concerned with? What do we think may have happened with those sets of symptoms? Yeah, we're worried about perforation. We're worried about an anastomosis site leak. We're worried about hemorrhage. So, with that, we are going to notify the surgeon. This is a surgical problem. If we are having an anastomosis site issue, that has to be managed surgically. Will we potentially increase IV fluids, measure the abdominal girth? Maybe, but the first priority is going to be notifying the surgeon to see if they just want to take them right back to the OR and fix this bleed. We might do some hemodynamic management in the meantime, but the priority intervention will be notifying the surgeon. With these questions, when you see that notify surgeon potential or option, you want to be thinking about, is this something that can be fixed by whatever other intervention is present, like increasing your IV fluids? If that's not going to fix the bleed, we might want to do the surgical option first. There's other times that you want to do an intervention, especially if they gave you a blood pressure and asked what would be the first thing you do, then that's might be a little bit different. But if it's a bleeding problem that needs to be handled in an operating room or with a procedure, then we want to prioritize that when we're assuming that the bleed is active. Okay, let's go on to this one. A 70-year-old with atrial fibrillation presents with sudden severe abdominal pain described as a 10 out of 10, but has minimal tenderness on exam. Which condition is most likely? There's a couple things in the question that should kind of make us think one thing or another. We're not given a ton of information. What do we think? A couple different answers coming in. Three. Oh my goodness, we've got all four different answers. And I don't blame you. We're not given a ton of information. We've got general abdominal conditions here that would lead to discomfort. So, how do we determine which one it is? So, I'll go ahead and tell you the answer here is D, mesenteric ischemia. And there's a couple reasons that we would think it's D over some of these other options. So, first of all, here we have First of all, here we've got atrial fibrillation. So, what is a main risk of atrial fibrillation? What can atrial fibrillation lead to? Why are we so concerned when our patients in AFib? Other than maybe their cardiac output being disturbed, what's the main problem with AFib? Yeah, awesome. Blood clot, right? So that blood clot, we normally think of stroke being our primary concern because of where the clot develops in the heart. It usually is going to become an arterial clot and it can go straight up to the brain, but it can also continue down that descending aorta and get into our mesentery. So a really big risk factor for mesenteric ischemia is atrial fibrillation. So we have AFib, we have the potential for a clot. We have sudden severe abdominal pain described as a 10 out of 10, but with minimal tenderness on exam. And this is just something to kind of know about mesenteric ischemia that isn't maybe talked about all the time, but you can have really, really extreme GI pain, abdominal pain. But when we go to palpate that abdominal area, typically you would expect there to be extreme tenderness associated with that. And in the early stages of mesenteric ischemia, we actually don't see a lot of tenderness to palpation. So this minimal tenderness on exam is what clues us in to maybe this is mesenteric ischemia, in addition to the fact that we know that we have a patient with a clotting risk that could obstruct our mesenteric artery and lead to that ischemia. So, because these other ones, like peritonitis, would definitely lead to tenderness on exam, as well as acute pancreatitis. Diverticulitis is likely not going to cause such a sudden, severe abdominal pain. It's usually going to grow over time as that tissue gets more and more inflamed. Whereas ischemia brought on by a blood clot happens instantly. So those are the things that kind of clue us in that this is D. Sometimes we're not given a ton of information, and you really have to think through, well, with the information they've given me, what could it lead to? So good job, everyone. That's a difficult question. Let's move on to this one. A patient with fulminant hepatic failure is admitted with severe jaundice, ascites, and altered mental status. Labs show AST 670, ALT 740, bilirubin is 5.2, platelets are 60,000, and INR is 3.1. Which lab value best reflects this patient's bleeding risk? Okay, a couple different answers. So the answers that I'm seeing most are A and C. So good job. You have read the question and knowing that it is asking about which best reflects this patient's bleeding risk. So it's not talking about the condition of their liver in general. That's when we would maybe think about their AST and ALT and their bilirubin. So excellent job. We're between A and C. And when it comes to bleeding, the best teller is going to be our INR. Our INR, our coagulation time, so PT-INR and APTT, are going to be more sensitive markers of bleeding than simply a platelet number. We never really know how that patient's going to respond to the number of platelets that they have. It's not uncommon for us not to transfuse platelets until they're lower than 20,000, sometimes even lower than that. So a platelet count of 60,000 is obviously low. But is it low enough to really reflect that they're at an increased bleeding risk? We don't really know because we don't know how that patient's going to handle that platelet count. An INR of 3.1, though, is definitely elevated, especially assuming they're not on any sort of anticoagulation. And that is a bleeding time number. So again, it's just more sensitive. It tells us more about bleeding risk than simply a platelet count. Hopefully that makes a little bit more sense. That's definitely a little bit tricky. We're looking at two numbers that relate to clotting and relate to bleeding. Your bleeding time numbers, PT-INR and APTT, are your most sensitive values for determining bleeding risk. Much more sensitive than platelet, even though we obviously care about platelets too. So excellent job. All right, let's try this one. A critically ill patient is NPO for 5 days and has stable hemodynamics. The team initiates enteral nutrition at goal rate. Within 6 hours, the patient develops vomiting, high gastric residuals, and abdominal distension. What is the best action by the nurse? Awesome. Yeah, so a couple different answers, but we mainly were over here with A, stop feeds and notify provider. The other answer I saw was C, reduce feed rate and elevate head of bed. What condition are we concerned about with all of these symptoms? What do we think has maybe happened? Excuse me. Goodness. Hmm. Yenicell. I hope I'm saying that correct. You're exactly right. We are concerned for obstruction. So if we are concerned for an obstruction, these are really severe symptoms. Sorry. I think I just took a sip of tea and it did not go down the right pipe. Um, we are concerned with obstruction. If we're seeing vomiting, high gastric residuals, and abdominal distension, that abdominal distension is really, really telling that something deeper is going on than just this person getting nauseous from the tube feed starting. We're really concerned for an obstruction, which would then be a provider notification. There's not much we, as a nurse, are going to be able to do about that obstruction. Now, if this just said the patient develops high gastric residuals, that's when we would maybe ask some questions before we stop feeds or discontinue feeds. Maybe we just reduce the rate and elevate the head of the bed. Um, or if they're seeing vomiting as well. That abdominal distension really clues us in that something more is going on, and we need to stop the feeds altogether and notify the provider. So excellent job. Oh my goodness, I think I'm dying. Okay, let's move on to the next one here. An elderly patient with GI bleeding has received 4 units of blood and 3 liters of fluids. Heart rate is 110, MAP is 65, CBP is 10, and urine output is 15. What parameter most accurately reflects ongoing perfusion needs? Yeah, great job, Cindy. Number 6 was A. Good job, Yenisel. Okay, yeah. Right. So when this question's asking what parameter most accurately reflects ongoing perfusion needs, meaning we are not properly perfusing. The best number here is going to be your urine output of 15. That tells us those kidneys are still struggling to get enough blood flow and feel perfused. The other one that was maybe distracting would be heart rate. Our heart rate here looks like it's still sort of compensating for some hypovolemia. Um, Meaning this map of 65 is great, but our heart is again having to go into overdrive to provide that map of 65 by offering a little bit of an increased cardiac output. But so that tells us that the body's still struggling a little bit. But when it comes to accurately reflecting ongoing perfusion needs, we want to see what are the organs doing, that the organs that are getting that blood flow from the heart. How are they doing? And if we're seeing this urine output of 15, that would be telling us a perfusion need a lot more than the heart rate. The heart rate kind of clues us in that something still is going on, but we know that we have perfusion needs if our urine output is less than desired, which our desired urine output would be 30 mLs per hour or half a cc per kilogram per hour. Awesome job, everyone. Okay, last one. I think I'm surviving now. Last one. A patient with an active GI hemorrhage and sepsis is on norepinephrine to maintain MAP over 65. Despite this, perfusion remains poor and lactate increases. The provider considers adding vasopressin. What would be the rationale for that choice? Good job, Yenisel. Awesome. I don't know if you missed one this whole time. You're doing awesome. You guys are really doing a great job. I'll give it just a second. Yes, the answer to number seven was D. Yep. Okay. Good job, everyone. So, yes, the answer to this one is C. Vasopressin is going to cause vasoconstriction in that splenic circulation, reducing portal flow, which is going to be particularly helpful when we're facing something like an active GI hemorrhage. We didn't hear where this bleed was, but any sort of GI bleed can benefit from the vasoconstriction to that splenic circulation, especially if there's any attachment to portal hypertension being part of the problem. Did we engorge some blood vessels that are now bleeding around the GI tract? Esophageal varices, for instance, but it could occur other areas in the GI tract. So that is why we like vasopressin. Octreotide is another one that not a true vasopressor, but can help with vasoconstricting some of those very specific GI tract blood vessels. Awesome. Great job, everyone. Good little gastrointestinal review. We also had a little bit of hematology in there with all of the bleeding that can happen. That's one of our main GI considerations and concerns. Excuse me. So that is why those come up when we're talking about GI. Let me copy this little link into the chat. This is our next webinar. We're just going to do another Rapid 30. Like I said, I do them about weekly. And then hopefully in 2 weeks, we're going to do another crash course type webinar, which is where we have a little bit more lecturing, a little bit less practice questions. And I'm going to work through some hematology concepts. Um, Yes, the answer was C for eight. Hematology concepts. So we're going to talk about DIC, maybe a little bit of HIT, heparin-induced thrombocytopenia, just work through coagulation studies, work through blood transfusions and what blood products we give for certain lab values. All of that. I love that information. And it's really good for no matter where you work in the hospital, what ICU you work in. We handle hematology conditions everywhere. So it's just a really good webinar that covers a lot of concepts that we all see kind of frequently. So that will hopefully come in the first week of July. But next week on Thursday, June 26th, we'll do another quick Rapid 30 going through practice questions, which I just love so much. I think they're so fun. So thank you everyone for being here and either use this QR code to sign up, use the link in the chat. You can go to archerreview.com/CCRN and see um, the the webinars listed there as well to sign up. Lots of different options. So we will see you in the